Welcome back to the Sensible Medicine Podcast. This is the podcast where we have a diverse group of experts brought together to discuss topical topics in the medical news. I'm joined by my friends and colleagues, Dr. John Mandrola, cardiologist, electrophysiologist from Louisville, Kentucky, and Tracy Beth Hogue, who is an epidemiologist, who is an expert sports medicine doctor. It is a pleasure to see you both.
Great to see you.
Someday we'll coordinate that better and we'll know. You say, hello. Okay, well, that's okay. We're getting ready. We're getting into this. All right, we got two big topics today. Topic one, exercise. How much of it is beneficial, healthy? Can you have too much of a good thing? Second topic, we're going to get into sort of the revisionist history on the COVID-19 pandemic. So let's start with the first topic. This is a really interesting paper, and I wonder if maybe, John, you might kick it off and tell us, the one thing I want to know is, I don't know the difference between regular exercise and ultra exercise. So what's that distinction? And the second thing is, what did these researchers just find?
Yeah, so this was presented at ACC, and I was actually at the presentation. This was a Belgian study, and of course, cycling and endurance exercise is really big in Belgium. And what they did is they sent out invitations through the media and got endurance exercisers to respond to this. And they had a little interesting technique. Is they actually recruited like 1,100 Belgians, and they then randomized to get 600. So they wanted to try and avoid selection bias, people who would respond to the invitation because they were sick or something. So anyways, then they separated. Of course, it's observational. So they separated the groups into lifelong endurance exercisers, and they used a METS category of per week. And again, the actual number is hard to pinpoint. And then really the other group was just regular healthy people who exercised either not at all or the normal AHA amount, 3 hours per week. The control group was interesting though, because these controls, they had no cardiometabolic issues, they took no medicines, and they had a 22% higher VO2 max than their age predicted maximum. So these were like specially healthy people.
Belgians.
And then what they did is they took these lifelong exercisers. Been 30 years, I think, was like the average of, and most of it was cycling, but there were runners and triathletes mixed in. And then they were interested in coronary atherosclerosis. So they then did imaging studies and a crap ton of high-level imaging studies of their coronaries. And so they looked at the coronaries of lifelong endurance exercisers and the coronaries of these really super healthy controls.
So Belgian people, but American testing. All right. And they claim that there is a J-shaped curve. In other words, it's not good not to exercise at all. It's good to do a little bit, but too much is actually bad, and you have an increase in coronary atherosclerosis. Is that right, John?
Yeah, but I think we should just without going into too much of the details, just like go into some of the details. So they found that lifelong exercisers had more coronary calcium than these controls. And previous work has kind of suggested that. And that they found that lifelong exercisers had a higher percentage of bad plaques, like multiple plaques greater than 50%, and plaques in the proximal coronaries. And then, they looked at like calcified versus non-calcified plaques. And then when they looked at non-calcified plaques, they found that lifelong exercisers had similarly, like, not the best coronary plaque characteristics. And then they looked at the vulnerable plaques, and it's above my pay grade exactly what a vulnerable plaque is, but they found that those were very low and in both groups. And so their conclusion was that compared to these healthy controls, lifelong exercisers didn't have these remarkable coronaries. So their coronaries looked probably worse or no better than that, which is interesting for two reasons. One, you would get the idea that like lifelong exercise is super healthy and it kind of could inoculate you against any coronary disease. And second, the other tension here is that when you look at other observational data, there's actually lower event rates in in people who exercise a ton. For instance, there's a very interesting study on retired Tour de France riders who have incredible survival and longevity. And so there's this tension between outcomes of endurance exercisers and these coronary arteries. And so
okay, this is good.
They propose in their presentation and in their discussion that there may be this reverse J curve where too little exercise is bad, of course, sedentary is bad, but there's this Goldilocks amount of exercise. And then if you do too much, then you might be doing harm.
Mm-hmm. That's what they want.
That's really a problematic conclusion in my mind.
Okay, and that's going to be the topic of discussion. Before we get to that, because I'm also going to take a big crap on this. Okay, before we get to that, Tracy has read it carefully. Tracy, what else do we need to know? What do you see that's problematic in this paper?
Yeah, so I'll just say, first of all, this is a study in European Heart Journal. I think you said that, by Debasher. People are trying to look it up, Debasher et al. And
nobody's trying to look it up. Nobody reads anymore,
okay,
Tracy.
right.
Nobody reads.
Masters at Heart. Masters at Heart is the way to find it, yeah.
Okay.
So I just have to get it off my chest.
Yes.
The thing that bothers me the most about this study is it was all men. And so I knew when I saw it was a European study that was going to be the case, because
why is that?
There are very few women in Europe who are like big time endurance athletes. And so I wonder, first of all, I wonder why they chose to do it that way. But that this has been typical of a lot of European studies of athletes looking at heart issues. And I'm pretty sure that John knows this too, because the initial studies of atrial fibrillation among cross-country skiers were done in males and not females. And then when they finally did the studies to include the females, they didn't find the same relationship between the dose-response relationship between amount of Wasserlöbet, like cross-country ski races.
Oh, that's the word. Okay, yeah.
And sorry, I was like, should I actually say it in Norwegian? But and the amount of atrial fibrillation that they had.
I see. So you're saying it was present for men, not for women. That's why it's very important to look at. Right.
And so I was really curious when you sent this, what the relationship was going to be for women and men. And then I saw, oh, it's only men. Okay.
Can I just stop and ask one quick question? What makes someone, and like, where is the amount of athleticism become elite? Like, what are we talking about? Are we talking about a jog twice a week, 3 times a week, 50 miles a week, 1,000 miles a week, 100 miles a week? What are we talking about? What makes you elite? That's what I want to put a finger on.
Right. So, I mean, the way that let me just see this. So the way that they did it in this study, I mean, like John said, they were really comparing people to not exercise, who did not exercise more than 3 hours a week. So this was like, John, do you remember the amount that you had to exercise a week to be included?
Yeah. This was not, these were not necessarily elite athletes who competed in big races, but so this was, I have the paper pulled up here. Athletes were defined as in cycling greater than 8 hours or running greater than 6 hours per week for at least 6 months prior to baseline. Lifelong, started regular endurance training at less than age 30. And then they also had a category in there of late onset exercisers that began after age 30. But we're not talking about people who do a Peloton 3 times a week at 30 or 45 minutes. We're talking about people who go for 3 to 4 hour bike rides on the weekend, who ride an hour or 2 every day, or run like Tracy runs. I mean,
we're talking about the 3 of us, actually, ironically.
Yeah. So
okay.
I would consider myself a lifelong endurance athlete, but not elite, which is, my friends would laugh. Definitely not elite.
But lifelong. Okay, Tracy, back to you. Phil, round out your thoughts.
So I just want to say that, again, this is an observational study, right? So I think John's point is very important, that these controls, the non-exercisers, are very different than usual non-exercisers, at least I would think in the United States, because none of them had hypertension, none of them were obese. They were sort of like a little bit over the middle of overweight. They couldn't be higher than that. They had to be lower than that. They couldn't have hyperlipidemia. They couldn't have diabetes. So already, you're comparing athletes to a very select group of non-athletes. So I think that that's an issue. And in the study, they were using sort of causal language, like implying that it was the exercise that was the risk factor that led to the coronary artery disease. Whereas we don't really know, it might have been something else. It might have been that these people who were non-exercisers had higher socioeconomic status, didn't work as much, slept better, did all sorts of other things that might be beneficial to their health. So this was like, all of these confounders that we see in observational studies that we've been discussing with COVID, like this is the same issue that we're seeing with this study, that we're looking at two like very different groups of people. And even among the athletes, they had a higher history of coronary artery disease or cardiovascular disease in their family, even though it wasn't significant. It was like the point estimate was higher. And then I just want to point out that we have like this long history of literature finding an association between like a dose response curve actually between exercise and then decreased all-cause mortality and decreased cardiovascular mortality, decreased mortality from cancer. So it's like, again, we don't know cause and effect, but when you look at, how often people die, we actually, who are athletes and what the association is, we have a long history in the medical literature finding like a beneficial association of regular exercise with mortality and cardiovascular mortality. So we were talking about they're looking at plaques, right? So what does the fact that you have like a coronary artery plaque or or calcification or a certain type of plaque, like what does that actually mean for your risk of having an event or your risk of dying? So we have all these studies where we have an endpoint that is like not meaningful to the patient. Like
it's a surrogate endpoint. It's a surrogate endpoint. Yeah.
Yeah. Like you always say, what Adam Sifu says about it, it's like the patient doesn't care about it until the doctor tells them they should care about it.
And I just want to make another point, which is that there's a vast literature on the risk of different coronary artery plaque and calcification. Huge literature. The bulk of that literature is not derived from ultra extreme athletes. And so the exact same lesion may have a slightly different prognostic significance in a different group of people. You just don't know. Okay, here are some thoughts on this whole space. I have to say, this is all, no, pardon my French, this is all shit. I mean, I think the study is shitty. I don't draw many conclusions from it. And I think we've forgotten what we're really trying to get at, which is people are reading this literature and they are trying to figure out how much exercise should I do? I think that's the question, right? That's the question. That's why this is in the news. That's why people are interested in this so much. How much should I do? And then the question is, why you exercise? And I think we all acknowledge one reason to exercise is, well, I want to improve my longevity. The other is I want to improve my physical function. Like even if I won't live longer, I want to live stronger. I want to be able to, walk to the mailbox until the day I die, that sort of thing. A third reason is the sheer pleasure of exercise itself in the moment. I think we have forgotten that many people who exercise a lot are doing it for the pleasure of the moment. I go on 3-hour bike rides on the weekends. Not as much as I used to, but I still do it frequently. I'm not thinking about the second two things. I'm thinking about the pleasure of the moment. Okay, so with that background, I think one thing the three of us probably all agree on, and tell me if it's true, we all agree that you would advise somebody who's sedentary to do a little exercise each week. I mean, fair to say?
100%.
Totally agree. The next thing we might all agree on is if somebody tells you they run 200 miles a week or 150 miles a week, you would say, that's awesome. You do you. If you love it, you love it. But if you're doing it and you're saying, I'm doing this because I want to live forever, you'd say you probably could get away with doing a lot less. If your only goal is longevity, I'm not sure you need to push it to 2 hundos a week. Fair to say we all agree on that? Sort of just an intuition. Okay. Now, the reason these things really bother me is that I really think that, and I just want to pick your brain on it, among the people who are truly this kind of person from the age of 22 or 18 or 27, they have been biking, hundreds of miles a week and running like this. If you told them these results, are they going to change their behavior? What do you think, John?
100% no.
100% no. 100% no.
Well, maybe not 100%, but 99% no. Okay,
go on.
Here's what I wrote. I wrote a column on this on heart.org, and one of the things is I'm biased, right? Because I like this, and I'm like the gerbil who needs to run on that wheel. I just have to run on a wheel, even if there's nothing in front of me. I got to run on it. But I've been on rides at 5 a.m., racing up hills. I've been on criteriums where we're racing for a $25 check, like it was a Tour de France. And I talk to these people, and none of them think this is healthy or they're doing it for health.
Okay.
I mean, getting up at 5 a.m. and riding 40 miles and beating yourself into the ground and riding 100 miles on the week and, training for a marathon. Now, maybe if you run like Tracy, okay. But if you run like a normal person, marathons, I don't see anything healthy from it. If Fibbities had not died, no one would care about a marathon. They'd run 10Ks. So I don't think that like people who do this do it for health, at least the vast majority. So,
and I think that's true. I just also want to add, I don't believe it's deleterious. I mean, I'm not persuaded that it's deleterious for health. I don't believe the conclusion. Okay.
Well,
yeah.
I don't either, but I will tell you from this is off the topic, but I'll tell you just from the arrhythmia clinic, and I do see people who are just beating themselves down into overtraining and these inflammatory states, and I think the observational evidence for arrhythmias in AFib is much stronger than for coronary atherosclerosis, and so I do think that in certain individuals, you can do too much or not rest enough, and I do think that is true. Whether that has any long-term longevity consequences, I don't know.
Tracy, you want to say something?
Yeah, I mean, I guess, I see kind of two different types of patients. And one of those types is when it comes to exercise. And one of them is like the type where they don't want to exercise, right? They'll use any excuse not to exercise. And they read these studies and they're like, oh, coronary artery disease, or they're like, oh, AFib, or knee osteoarthritis, like, and then they're like, what's even the point? Why would I do it? It's dangerous, right? And so then it's like, I'm sort of like talking them down from these studies and saying, there are many health benefits to exercising. And like, we don't have randomized studies, and it's not just physical health, but it's physical health, it's mental health. I mean, and just getting outside, just, there are many, and not just that, the camaraderie of like sports, and there are many aspects of like health that come with sports participation, but like, I worry most about those patients that just do not want to exercise, and it's not just that, you decrease your blood pressure and you lose weight, but you're stronger. And, I see a lot of patients who have difficulty, just like Vinay said, like maybe walking to the mailbox or doing like your activities of daily living. And the stronger you are and the more you exercise, like, the longer you can, on average, postpone your time to getting to that point where you have trouble like getting around and doing your activities of daily living. And so, I worry that if patients don't like develop the right habits when they're younger, that they're going to age more quickly. And some of it is frailty, right? It's not just the heart, it's sort of like the whole picture. And
to be clear, like the problem in America is not that there are too many ultra athletes, it's that we're sedentary with obesity crisis. That's the problem. So right, you're right. So for every person you're dissuading from exercise, that's the problem. But my overall thoughts on this issue, I should have spelled it out. I mean, this study I think is very low value. One, because it has a huge conditioning problem, like the people are being self-selected. Even if you randomly sample from the self-selection, you still have the self-selection. The second, all the endpoints they're looking at are surrogate endpoints, which are dubious. And we have this huge selection filter on the front end, so we really don't know if this is a causal relationship at all. I mean, that's easy. It's, low credibility, doesn't tell me anything. And the types of people who are ultra athletes are different in many other ways, as Tracy pointed out. Okay, so go on.
Tracy, wait, you said there's two types of patients. The first is the ones who don't exercise.
Yeah.
What's your experience with these others? Because I have experience.
I do think that a lot of them are doing it for health. I kind of disagree with you on that.
You mean the ultra people?
Yeah, I mean, I do see a lot of ultra runners. I think they take their health very seriously.
Okay, and, yes, I think that's true. But are they doing it for health? Go on, finish your point. Sorry.
I think it's a combination. I don't want to, say that, the same thing applies to everyone, but I definitely find like that that the ultra marathon runners that I see, and I see a number of them, like their participation in ultra marathon sports is like a piece of their whole effort to being like very fit and a healthy person. And so I think, that a lot of ultra athletes will acknowledge that they don't need to do that much to get the health benefits. And so there's sort of this extra, like, that you want to be competitive. That's definitely the way I used to be. And, when I was like super competitive in ultra marathon running and long distance running, I did not think it was unhealthy. I mean, but I didn't think that I needed to do that much for it to be healthy. And I think there's a little bit of like speculation that just because you're running over 100 miles a week, that's necessarily unhealthy. Like, I haven't really seen.
Correct. That's what I want to say too. Yeah. Go on. I think the only thing I know for sure is it's better to do some than none.
Yeah. Yeah. And I think a lot of it is just sort of finding something that you enjoy doing. I think there's many health benefits in that. And I do think a lot of like ultra endurance athletes do it for mental health reasons.
Of course. Which is the euphoria that comes from it.
Yeah. I mean, exactly. And not just that, but just sort of like, like just feeling more balanced mentally. I think that I've noticed that a lot, like where ultra endurance athletes tend to maybe be the type of people who are prone to addiction or something like that. And then they find like, okay, well, if I participate in this sport, like that's a way better, a healthier activity for me to get involved in, than like. And
the reason they're doing so much is it's an addictive personality feature to just keep doing more of it. So I think I have two principles. One, better to do some than none. And the second is, obviously, like everything in life, there has to be some diminishing return. So going from 30 miles a week to 80 miles a week to 200, I doubt you're getting much. But again, I think the one point I want to make is that many people are interested in this question, and medicine has almost no answers. We have just totally failed. We have no answers. We never even tried. We never studied. We never do randomized studies. We just waste our time with retrospective garbage like this, or cross-sectional garbage like this. We've never even tried to answer. We've just totally failed you. All we can say is, hey, get off the couch and do something. And, that's about all I know. Okay. John?
Yeah, I agree. Two quick comments and we'll move on. But I appreciate your saying that, Tracy, because your experience in California with ultra marathoners may be different than my experience with bike racers in the Midwest, and so it might just be that we're seeing different populations. So that's good. But I think the other point, Vinay, that to yours is that we have headlines that say endurance exercise tied to more coronary atherosclerosis, and I think that the mistake we make, which may be a segue into the next topic, is to make these outsized conclusions from really a flawed observational data that's not worthless, but it's certainly not something that we should make these kinds of conclusions from.
Yeah, that's well put. And the irony is that if we actually came on this show and we spent like 4 hours talking about ATP production and VO2 and all this, we'd be much more popular. I mean,
it's mind-numbing. It's mind-numbing.
But there's a whole industry, because this is my last point. The people who consume podcasts about exercise are not the average Joe. They tend to be rich, well-educated people who have the luxury of time. So we can spend our time, pontificating about, should I go for that extra run, or, biohack my life and drink smoothies and all this bullshit that's very popular where I live. And, we rely on low levels of evidence. We're already rich and privileged anyway, so we're probably going to do fine no matter what. And then we spend our time, and there's a huge industry of people who are happy to sell you a supplement in the advertisement while they talk to you about why 20 miles is the right distance, not 40 miles. And then you'll see all these tech bros tweet, I've gone down to 20-mile bike rides because of a great podcast on whatever. It's ridiculous. Nobody knows anything other than don't be overweight, do some exercise. And the other thing about life is if you enjoy it, do it. What the hell you want me to tell? You enjoy it. I enjoy the 100-mile bike ride. There's something I like about it, Is it addictive personality? Is it competitiveness? Probably to some degree, but it's also just being out there in the trees and in the woods and the trail, That's beautiful too.
The truth is, Vinay and Tracy, that I've been doing bike racing for 25 years, and I have tried every pill, supplement, altitude training, and everything you could try. And the results of the race are always the same every year. Like the top guys always win, the top women always win, and it just is what it is. And so all of these things I totally agree with you. I barely have a computer on my bike because it doesn't help. It's just by feel.
Tracy, last word on this, and then we go to the other topic.
No, I found one thing that really, really did help. It wasn't a randomized study. I'm sorry. I can't quote.
That's okay. Tell me. I'm curious.
It was running multiple marathons and running even 13 to 16 miles a day when I was pregnant.
Oh, God.
And you guys think I'm crazy.
I think you're hardcore.
But I will tell you guys that after I had my second child, I could not believe the performance increase that I had. And there's so much literature to back this up, because you end up having a higher VO2 max after you train, like while you're pregnant. And then there's just the growth hormone and the change in your hormones while you're exercising, while you're pregnant, that it's sort of like this unique opportunity. And so that's the one thing I've come across that really made a difference. So
that's well put, but it's hard to replicate.
Okay, I have to ask you this, Vinay, because I've been wanting to ask you this forever. A randomized study of exercise.
Yeah.
Okay, so like how long? Like we're talking about these people who exercise for like years.
Yeah.
You can't do this study.
No, yeah, you can. I think yeah. Same with alcohol. We did have an NIH study about alcohol, but here's the thing. Here's how you do it. I have a post written about alcohol. One, you have to, this is my philosophical principles. Then we move to the other topic real quick. Okay, one, I think we all have this idea you're going to randomize people to exercise, no exercise. That's not how it can possibly work. Everybody is entering this study with some baseline. Tracy runs 12 miles a week or 20 miles a week. I run 10 miles a week. John runs 30 miles. I don't know what it is, something like that. So you take people, depending on what baseline you are, and knowing that people will be different, you get a lot of people. A lot of people. So you're going to get some people at 10, some at 20. Then you start to have many arms of the randomization. You randomize people like me, and you say, VP, whatever you do, add 20%. You randomize you to the arm, Tracy. Whatever you do, subtract 20%. John, more extreme, 50%, 70%, up or down, whatever. We give you some advice. And then we follow people for years. And the real question is this. What are we testing? We're not testing exercise. Because to some degree, that's not the question. The question is, we're testing what should you advise someone in the world? Should you advise him to crank it up a notch or crank it down a notch? And that's what people want. They want to know what you should advise them. And I think no matter, even with attrition, even with, first of all, if nobody complies, that already answers the question. Save your breath. You should never advise anyone because no one's going to change what they do. Okay, so that's the answer to the question. But if everyone does comply and in one direction they have improvements in health outcomes, and then what are the outcomes I'd look at? I'd look at longevity, because you could do it in 65-year-olds, and you could look at Look Ahead, which is a type 2 diabetes study by the NIH, ran 120. Okay, you could get some signal. You could look at morbidity, osteoporotic fractures, falls. You could look at all the. Okay, anyway, we'll save that for another time because I want to talk about.
So you're randomizing advice, not exercise. So
correct,
it's a little bit different.
No, but I think that's what we're doing here, because this news story is not exercise. It's how you tell somebody about exercise. It's an advice. The podcast we're talking about, it's not changing what you do. It's advice. You should do more, should do less. In this business of health medicine, we are, even public health, it's mostly advice, except for the mandates, which, you could randomize to mandate, no mandate, and see it blow up in your face. But most of what we do is advice, and advice is what people crave. And I think the advice, my gut is that getting people to move from nothing to something will have some positive benefit, but everything else is just, not going to do much. But anyway, that's my null, but we'll see. But NIH could pay for it. Okay, anyway. All right, next topic. It's a good question. And people who are interested, they can read my thing on alcohol, because I kind of flesh it out more. How do you advise somebody to drink or not drink? I kind of have a post on that. Okay, next topic. I'll give my intro, and then we'll have John take it because he wanted to frame it in a certain way. But the way I would frame it is this. If you read all the randomized controlled trials of masking pre-pandemic, there's no question in my mind. The answer was, It doesn't work. Community mask advice does not work. Cloth masks don't work. We have a cluster randomized trial by McIntyre that showed that. The advice was not to do it. The CDC came forward in March, early March. They said, don't do it. WHO said, don't do it. You know, it was universally accepted, don't do it. Fauci goes on 60 Minutes. He says, don't do it. That's because they're all telling you what they believe. Then, in the first 3 weeks of March, there was a vigorous push for hashtag masks for all run by a computer scientist. And this, I might mispronounce her name, apologies, nothing meant by it. Zeynep Tufekci, who is a computer scientist, she wrote an op-ed and she says why we should mask. What she didn't say was why we should do a randomized trial of masking, which would have been the smart thing to do. She just pushed it. The CDC saw that op-ed. They've released some internal communication that said that's why they changed the recommendation by April to recommend masking. She has taken credit for that. And that was in 2020 when mask popularity was through the roof. As the years go on, we've got at least 2 randomized efforts during COVID, Bangladesh, which has a concealment bias issue and is practically negative, and Denmark, which is negative. And then we've got Guinea-Bissau, which is not that useful. And then we still have all the pre-existing studies. We've got some studies in healthcare populations, which is a good study that showed N95 is not better than surgical mask. Non-inferiority margin was large, but actually I think it's reasonable. I defended that elsewhere. Okay. Now the consensus is, well, community mask mandates don't work, and surgical masks don't work, and cloth masks don't work, but if you wore an N95 mask, like, that would work. So we have totally backtracked on the position from advising people you ought to wear a cloth mask or you're a MAGA idiot. You know, that was the March 2020 advice. Now the position is, well, yeah, mask mandates don't work, and they probably didn't work in 2-year-olds because we took it off for naps, but if you could still wear a high-quality mask. It's a huge retreat. And my opinion, then I'll give it to you, John. The same people now are who told me all that bullshit about how sure they were that it works, ignoring all of the randomized data, actively subverting us who wanted to do randomized trials. They sabotaged those studies. They sabotaged it. They made it hard to get a peer review article through that wanted to do randomized studies of masking. They attacked anybody who said you shouldn't mask kids. Viciously attacked. Okay? Those same people, now they come to, oh, well, Cochrane's inconclusive. We should have run randomized studies. And I'm like, go fuck yourself. I'm sorry. Go fuck yourself. You were wrong then. You're wrong now. You just don't want to admit it. And you are the reason we didn't do the studies. Okay. So it's a revisionist history. My point is at least Tracy and I were the most outspoken. We were right. They were wrong. Okay, John, how do you view it? And I'm a harsh man, so forgive me.
Well, I do think it's a hot topic, and it's politicized, but I do want to elevate to the grander concepts of how we know things and how we can learn from history. So I was just a couple days ago at the UCSD and talking about this sort of view that I have about medicine, this medically conservative view of slow adoption of progress. And some of the points that I made and some of the reasons why I've come to this sort of conservative, not politically conservative, but just conservative approach to things is because of all of the things that we've been fooled about with believing marketing studies, with really lousy endpoints, with not considering multimorbidity, and the big one, and I come back to this again and again, is leaning too much on observations. Like, for instance, the anecdotal study about the hairdresser the hairdresser anecdote. And so when I started cardiology, you guys, we had these premature beats at patients who had heart attacks, and it was a certain thing that these things were bad. That was true, observational studies, and that we had drugs to suppress them. And so you could not, it was just like masks. You could not, maybe not just like masks, but you could not question the therapeutic fashion of treating these PVCs. This was the right thing to do, and to not do it was terrible. And then finally, when people got the guts to randomize to placebo or drugs that suppress the PVCs, we found out for a decade our treatment was killing people. The number needed to kill in the CAST trial was 29. For every 29 patients we treated, the way the experts said, we killed patients. It was the same with hormone replacement therapy. Digoxin has been maligned by the same way. And so I'm more interested in looking back at some of these things that we now accept and understanding why we came to these conclusions and why we believe these observational anecdotal studies. And to me, that's the grander message is how we know things.
Well, that's the topic of the book Ending Medical Reversal, because I agree with you, which is that was what we set out to do, which was we have flip-flops in medicine. Why do we have flip-flops? Because we adopt something based on low credibility evidence. Why do we do that? Because we want to believe, we have financial incentive to believe, and when we're scared and desperate and dying, we will, a drowning man will grab for the blade of a sword, that saying. And so that's why we do things in times of crisis. Now, the rational part of the brain should be there and say, okay, it's okay. You're scared. You want to do something. That's okay. But let's do some data collection. Let's do some randomization. So in the next 6 months, we'll answer this. And so I wasn't opposed to masks in 2020. But I was opposed to 3 years of endless masking with zero positive studies that have anything to do with the USA. That rural Bangladesh study excluded cities in Bangladesh. It didn't even go to the cities. And it also has a lot of problems, which we could talk about. Tracy, thoughts on this? I agree with John. That's the broader philosophical question. We'll talk more about that.
Definitely. I mean, this is really relevant to what I've been doing actually a little bit this last week. I mentioned this to you guys because I have been an expert witness in this case against the Calvary Chapel, who has $2.9 million in fines for it was initially for them opening early, but then the most recent fines have really been mostly about them not adhering to mask mandates. So
where is this chapel?
This is Santa Clara County, and this is David Zweig, his article, what he wrote about the church. And so basically, as part of my testimony, I had to go back and think about how I was looking at the mask data from the very beginning, because this was a question to get to what you're talking about, John, of how do we know what we know? And what did we know at the beginning of the pandemic? And I didn't know you guys, but it's interesting because I had the same philosophy from really reading the medical literature of we don't really know until we have very good high quality data or randomized study to show us that this actually works. And so at the beginning of the pandemic, over the summer, it was really midsummer that we started saying 2020 that masks work. And so I immediately started looking at these studies that were coming out and noticing they're mostly modeling studies. And I said, wait, what are these models? What are they based on? What study? And so I'm writing to the authors of the studies and what are you, trying to see what they're basing it on. But there was no randomized data that showed that masks work. And so even now in Zynep's article, she's going back and she's saying the randomized study from Germany with high compliance, it showed it worked if you masked early. But if you look at their pre-specified endpoint, the mask didn't work. And she's talking about this per protocol, when they
post hoc,
people who only masked in the first 18 hours. And then it's but you lost the randomization. This isn't a randomized study anymore.
Can we just say that one more time, which people don't, this is true for colonoscopy. It's true for this. You run a randomized study because you're equilibrating outcome distributions in the absence of therapeutic effect. If you only look at people who did it one way or not the other, those are not random. Those are people who have certain covariates. Yeah, they're different people, right? So it's not a randomized study anymore. All right,
suddenly it's an observational study once it's per protocol.
Right,
and
correct.
And so that's, has been the big picture, is that journalists like Zynep, I know that, she says she's a scientist. I don't want to say she's not a scientist, but what she's doing is not scientific, because she's filling in the gaps in our knowledge with things that she's assuming or making up, or, she's filling in the gaps with bad data.
With supposition.
And so that's what we've been.
But one thing I'll defend her on.
Seeing from the beginning. Yeah.
One thing we have to point out is that you could take an MD, PhD epidemiologist, and they'll agree with every word she said. So I don't think it has to do with her background or skill set, because there's a lot of MD, PhD epidemiologists who don't know how to interpret data too. I mean, they're not good at it either, in my opinion. Okay,
totally. But it's unscientific, and I'm not saying anything personal about her. A scientist will look at that and say, what don't we know? And what do we have really good data to support? And so what is a scientist doesn't look at like uncertain data and then fill it in with like observational.
Well, there are a lot of scientists who do,
so, like,
but they're just not
scientists, right?
Okay.
That's not the scientific process.
Correct. I agree with you. The problem is there's only like 10 of us true scientists. But
but we've had a lot of journalists do that, but we were also inundated with articles and observational studies from the CDC,
propaganda,
and publication bias
propaganda
from journals, yes, saying masks work. And it's like, I look back at the old studies, and even like studies that were about predominant airborne spread of SARS-CoV-2, they're like, this is why we should mask in the conclusion. And it's like, what? Where did you get that conclusion?
John?
So
that's well said. Well said. Come back to this.
So one of the other topics of ways of knowing is that, and I think this has been published, is that randomized controlled trials are not very good at looking at harms. So they're good at looking at benefits, and we look at benefits, but we don't really look well at harms. And so here's what I'm thinking, and I'm not a public health person, I'm just thinking, but if you're interested in the public's health, then you need trust. You need trust. You need your recommendations to be trustworthy, and you need the public to go with you. And so here's what I'm thinking. When I pick up my grandkids and they're asleep on the cot and they don't have a mask on, but they're breathing on each other, I'm thinking to myself, okay, if that's the policy, it's so bad and so dumb and so nonsensical, then I start thinking, if I was a doctor and I was recommending such nonsensical things, would patients believe me about exercise and about taking their statin or their blood pressure pill? They'd say, this guy's a goofball. And so I think there's a cost in having goofball policies. And this is the thing that when I went to Denmark and when I met them, and they said, we trust our public health people. And if you're interested in the public's health, then you need to build trust. And so this is the thing that really got me, is that we didn't really consider the off-target harms. And I think one of them is mistrust.
John, that's a great example. I think you're absolutely right. What are the things people mistrust us for? You taped up the playgrounds. There's a professor at your university standing on the beach screaming at people surfing that they're going to get COVID. You took the rims off the basketball hoops. In San Francisco, they tried the second time in like a fall lockdown of 2020 to close the parks, and then they did it for one day, and then they undid it because like there was so much pushback from the community because it was just overwhelmingly stupid. The policy was make the kids mask 2 to 4, except for when they nap all in the same room with stagnant air for 2 hours. And that was one that I thought, like, I'm going to take credit for that because I was the one who observed that. And I put that and I said, this is like a trump card. It's going to get everyone to change their mind. And then I wrote those articles in The Atlantic and stuff. And I was really pushing in that year for this stupid policy to end. And I kept playing that card. And I will tell you, the people pushed back so hard. Oh, no, what do you know? Blah, blah, blah. I was like, what do I know? I'm not a moron. That's what I mean. Only an idiot would think it would work. And that is the position of the American Academy of Pediatrics. What am I to think? What am I to think, John? That is their position. There's not anybody in the AAP who says, guys, before we start making these toddlers masks, maybe we should like make sure they don't chew it. And then the second thing is maybe we got to solve this nap issue because we're going to look like idiots. Nobody said that. And now in the Zeynep piece, she cites that as an example of excessive policy that she never advocated for. But I didn't hear her advocate against masking 2 to 4-year-olds, which is an extreme. It's an extreme by European standards. It's an extreme by common sense. My friend from Europe he always says, you don't even need to go to college to know that's not a good idea. You just need to use your eyes and it's like not good. Okay, I just want to bring it back to John's thing. To me, the masking question was the ending medical reversal story. I have been in this sandbox for 10 years, always curious about like, why do we adopt things on low credibility evidence that blow up in our faces? And I watched it play out in front of my eyes. And I tried to tell people like, hey, let's run some randomized trials. And then they attacked me. It was a parachute. It's unethical to run the random. Those are always, those are wrong. And now we're left with no data. And the last thing I want to say, and then I'll let you talk, Tracy. It doesn't even make sense anymore. Okay. Like even if you believed in it, the relative risk reduction's got to be 5 to 10%. I mean, nobody can possibly believe masking's like 95% reduction. It's not that good. Okay, like if you advise people to wear a mask versus not, it's gonna be like 5% delta at best, like something modest like that. So if you do that before a vaccine, maybe you'll punt another 20K people to get COVID on the backside of a vaccine, and then you're like, okay, that's good, man. 20K people got it after vax rather than before vax. Totally. Like, we save some lives. IFR is different. It's a different business. But if you go in 2023 and you make people wear a mask and get it in 2023 October rather than August, and this is like best case scenario, and by the way, I don't even believe it does this, but best case, what would be the point of that? What is the point? And that is something that I sometimes get, people write back to my column and they're like, oh, well, my loved one is immunosuppressed, or what about that? And I'm like, I hate to tell you the harsh reality, which is that anybody who's going to spend 20 years on this planet, immunosuppressed or healthy, is going to get COVID-19 more than once. And that is a reality. And then the question is, how much do you want to ruin your life when you get it when you're going to get it anyway? And that's the question you face. And the answer is, you should do exactly what you did in 2017, which is, all the immunocompromised people, we just lived with it. That's life. Sorry, but that is life. We're all going to get respiratory viruses. They cannot be stopped. They live because we're human beings and we have to be close to be human. All right, Tracy. Sorry. This is my pet issue.
That's good. No, but I agree with you, John, that I think that we, it's the children and it's in healthcare settings now that we're masking. And it's at the point of absurdity now, right? And Europe, we can compare ourselves to them where they have much higher trust in public health, as we've discussed before. But it was like over a year ago that Denmark, I know, stopped masking in the healthcare setting. And of course, they never masked kids. And so, all along they've been saying, well, we don't really have that good of a data that masking helps that much. And they did it for a while, in public transportation and things like that, and kids over 12 in school. But now it's gone. And so now it's like, I do experience, with my patients that they think it's so it's not congruent with the rest of their life that now they come to the doctor and they have to mask up, and they're like, well, why? And so, they know that it doesn't make sense. And so people are associating going to the doctor with things that don't make sense, things that make them uncomfortable, this feeling that they cannot communicate with people, this feeling like they're not being heard. And I think this gets to the other problem that I want to bring up, which is that physicians and scientists who have been speaking out about this have just gotten in trouble over and over and over again. We just get punished for saying we don't have the data to do this. There are likely harms of doing this. We can see the harms with our own eyes from doing it, with our communication with our patients, and kids not being able to hear each other. We've been bringing this up all along, and we just get punished for doing it. And it's so I'm looking back now and thinking about how much criticism I got for saying kids shouldn't mask in spring of 2021, and I know Vinay was saying that too, and I'm like, but we were right. And so many other people probably thought that at the same time, but they couldn't say anything because they would have gotten in trouble. And it's just this theme that keeps coming up. And now, to get back to that cold court case I've been involved in Santa Clara, it's like this little church, they have to pay $2.9 million in fines for doing something that never actually worked in the first place, as far as we know from the data. And so it's like it is absurd at this point, and people have been very hurt by the fact that people have jumped to conclusions about data and about how well things work before we even had the data to say they did. And I mentioned to you guys earlier how you had argued for medical conservatism, and I think that we need that in public health too. We need.
Don't tell them that they're going to scoop our article, Tracy. They're going to scoop our article.
But I think, Tracy, though, I think it gets back to trust, and I know that the public health experts might push back about me trying to make analogies between what we do with individual patients and what we do with public. But for instance, Victor Montori at Mayo Clinic has written about minimally disruptive medicine. And I wonder whether minimally disruptive public health, imagine the counterfactual world in which people thought about this and just said, well, we're not gonna mask kids. These things might have relative benefit, but go ahead. Imagine a counterfactual world in vaccines where we didn't force vaccines in the healthiest populations, young
Right.
college kids, and they just said, well, for them, we're not sure. It's up to you. You can do it, but we really think we ought to do these higher risk people. We do this in clinic when we have a patient with diabetes and they can't afford their medicines. We have to pick. We can't give them 6. We have to pick the top 2, and so we practice sort of this minimally disruptive approach. And I wonder whether one of the things we could learn from this experience is a more minimally disruptive approach to public health. And it's just an idea, and I'm just thinking out
brilliant.
loud.
It's brilliant. And you know who did that? Denmark. I mean, you're describing the European strategy, and it's brilliant in many ways. I mean, one is like exactly as you say, you only have so much credibility and power, and you have to use it wisely. And if all that, in this country, we've bungled so many things. We prioritized the intern in the residency class over the 80-year-old who is in the community. That is a very bad decision. The risk to the 80-year-old is maybe 100-fold or 1,000-fold higher than this person because their odds ratio is only 2 that they're going to get it. Okay, so we're making
normal.
Normal, right? We're making all these bad choices, robbing us of credibility. We abuse the mandate stick in the population's least at risk. To this date, the people who are most mandated are college men who have the least to gain and the most to lose from perpetual dosing. And here's the thing that the public health people, because I've talked to some people who I'm close to, and they say like, oh, the thing I disagree with you is that in public health, you have to act. You can't not act. And you have to do what's best for everybody. You can't just think about individual rights and freedom. You have to do what's best. And I say, okay, I just say, okay, let's just concede your premise. You have to act and you have to think about everyone. Okay, let's just concede that. How do you explain 0 randomized trials in the US on masking? Why is 0 the right number? And the answer is they can never defend 0. No rational person can defend doing it for years and never studying it. You have to be dropped on your head to have a policy of just doing it, yelling at people, calling them like idiots for not doing it, and never studying it. That was the policy. And the person who pushed it is the same person who controls the funding. Okay, I get worked up. I mean, Fauci, he controls $5 billion of federal funding for randomized studies in infectious disease, and he's the one who flip-flopped and is saying this. He should run the study. Walensky should run the study. She is in front of Congress as of 3 weeks ago. She is lying. She says there's no equipoise. That is a lie. How are we allowing someone to lie to the public that there's no equipoise? And that is why people are so angry at us, because these people are lying so hard that we know so confidently it works. So when Tracy and I write our article, we get so much vitriol because they believe these people. And why do they believe them? Because they have better titles than we do, to be fair. And to some degree, why do people believe what we believe? It's very political these days. Like, it's very hard to be like me. I'm a Bernie Sanders supporter who, except on all COVID issues, DeSantis is 100% right. It's very hard to be that kind of person. And I just want to touch on 2 things. Tracy made the point that people who spoke out paid a price. I think that's why some of us are sore. That's why I'm sore. But I know that I'm going to be vindicated. And to John's point about trust, I mean, it's over. I mean, you're right, John, but it's over. If there is a pandemic tomorrow, this country is going to rip in half. And here's what's going to happen. There may even be calls to, I don't even want to speculate. I mean, maybe even some states may try to secede from the union. You know what I mean? It might get that crazy because we know every red state is going to put their middle finger up. And it doesn't matter what the IFR is. They're just going to try to do as many things as possible. Every blue state is going to put all these restrictions on, and you're going to get the movement we've gotten, which is everyone is leaving San Francisco and moving to Miami. So a lot of us, and this time maybe I'll go too, because I've had enough of this stupidity. But we'll get migration. We'll get total chaos. And it is possible that the next time around, actually, there were some things you should be doing, that might have been helpful. And we will miss doing that because we're so, as you say, there's no trust. I don't trust, the last thing I'll say, and then I'll let Tracy comment. I do not trust the CDC at all. And I started this pandemic, I trust them everything. I never doubted them. Once upon a time, I disagreed with them about, latent TB testing. We wrote a paper and then they changed their policy and I was pleased with them. You can go read our paper in the American Journal of Medicine by Jenny Gill and I. But I never distrusted them. Now I don't trust them at all. I don't trust that their death count is accurate, because it isn't. I don't trust that their advice is thoughtful. It isn't. Their MMWR, I wouldn't even tear it up, because I don't even want to touch it. It's so shitty. It's such a bad journal. Okay, Tracy, thoughts?
Yeah, I mean, I think that the trust is key, right? But I want to push back on this mandate idea and what John was saying about the vaccines, because the childhood vaccines, because I think that there are childhood vaccines that are very important, and I don't want to give anyone else any other impression, but
we agree with you on that. We agree with you on that. Yeah, we both agree with you.
But
yeah.
I agree. So we all agree on that. That's what we agree on. But the point is that there's really only like 4 or 5 European countries that mandate childhood vaccines for school, and the rest of them, it's entirely optional. And those are like Eastern European countries, a few that mandate them, like the United States does. And despite that, they have very high vaccination rates in Europe. I know France has had some issues with lower vaccination rates, but in the Nordic countries, they have very high vaccination rates. And so there is this question of like, can you really have informed consent with mandates? And, to what extent is it public, like the people in public health, to what extent is it their responsibility to explain to people the importance of the vaccines and to help them to make the right decision for themselves and the community? And like, what is the downside of having a mandate? And like, is it going to result in people losing even more trust and sort of rebelling even more? And so, I think it's a really important discussion to have, because I think, when you look at our list of like vaccines that we even recommend, it's much longer than Europe. I mean, that's a different discussion, but like, I guess it's like we maybe can learn something from Europe and like the informed consent, approach, and like giving people the information that they need to make the right decision, and that more and more mandates are going to result probably in more backlash if people don't feel like they're being given the information that they can trust.
Tracy, you're 100% right, but these people have not learned the lesson. They have not learned that lesson, Tracy. They still have not learned it. You and I wrote that COVID vaccine mandate is not going to go well in California schools. They couldn't do it in LA. They didn't have the courage to throw out, what was it, like 40 or 60,000 children from school who are mostly Black and Latino and not Asian and white, because it's racist policy, by the way, because there's differential uptake by race, and they're poorer kids, and they need school. And you know what they don't need? The COVID vaccine, because they already had COVID. What are we even talking about? Throwing a child out of school and just destroying their life over a vaccine that you could debate whether they even need it? And it doesn't stop transmission anyway. What are we even talking about? And thankfully they didn't do it, but they haven't backed away from it. They got a new bill where they're working on something else, and they're going to come back to it. They have not learned this lesson. Yeah. They've not learned the lesson. And the last thing I want to say about the church, I read the David Zweig piece, and the thing about the church that blows me away is, I think you have to acknowledge one thing, that and I'm guilty of this too. I have an MPH from Johns Hopkins. I'm a public health person, and I am not a very devout person, And when I put my science hat on, I am not, I'm a very scientist hat, And that science hat is not a religion hat, okay? Let's be honest. So public health people, generally, I don't think much of religion. It's just the nature of the business. They had policies in this county that the museum was open, but the church was closed. And the liquor store is open, but you cannot in this country, you cannot treat a church worse than a museum. What are we even talking about? This is a country that one of the foundational values is people are free to have religious worship, and you cannot interfere with that religious. That's a foundational constitutional value. And this district has stricter policies on the church than on the museum. Why? Because we like museums. The people and that to me, it just blows me away. The public health people are so nakedly about what they like, their preferences. Soon it'll be like, you can buy red wine, but you can't buy Bud Light. You know what I mean? It's really like, you can listen to the opera, but rock concerts are closed. Like, we cannot live in a world where it's just my preferences. And that's what public health is. That's why that Zweig piece hit so hard. The policies were absurd. It was so cruel. And then they not illegally, I don't know if that's true, but they put them under cellular surveillance so that if too many cell phones gathered in the church, they would know to issue fines. You're using cellular surveillance on people who are trying to find God? What is wrong with you? That's such an abuse of power. To John's point, like, if you use the police state and you beat a man for not wearing a mask, this is not acceptable in a free society. I'm sorry. This is like, last thing I'd say. When I went to public health, I learned that in public health crises, when you want people to do the right thing, you make the right thing so desirable and easy and fluid that they do the right thing. And like, hey, listen, guys, of course the bar is open, but we're going to open this tent out here, have free drinks, have a party in this open air area. You can go to the bar if you want. I'm not going to close it. But if you want some free drinks, enjoy. They're going to come out of the bar, so public health is to entice you. It's to treat you with respect and to build, to strengthen you, to give you resources. It's not to get the cops to put you in cuffs. What are we doing? And this church stuff is really disappointing. All right. Tracy, you want to comment? Then John.
No,
Okay.
I agree with you that it was very much religious discrimination, and it was like it was very anti-American actually, and I'm not religious either, and I got involved in it because it was like it was wrong. It was wrong to focus specifically on this church, and then it was also like you said, these public health officials like telling these people, like you're telling like a 65-year-old man or whatever, like, no, you're not allowed to go to church. Why? I don't know, based on, I don't know, a model or like, you're grabbing things out of thin air and telling people how to lead their lives and taking away that's something that's so important to them for like months on end. And then it's not rational because you're not, treating church like other places. So I completely agree with you. And I just can't, the school that I was a medical advisor for was very similar to this church because like we opened as a daycare so that we could open as a school full time. Like that's how we officially got to open. And then I advised very early on that they'd be allowed to like play with athletic equipment and play sports and then unmask like very early. And like if we had like the CCP style, like, spies, watching us, then our diocese could have ended up with like millions of dollars in fines too. And for what? For being right. And so, I hope we learn lessons from that maybe we shouldn't be telling people how to lead their lives for months and months on end without having data that the benefits outweigh the harms. We certainly never had data like that.
And not only do you tell them how to live the life from a tradition that goes back 1,000 years for your tradition that goes back 10 seconds, and you got no data to support it. That is really what it happened. Okay, John?
Yeah. Just finally, it just goes to that minimally disruptive approach. The mandating of masks, the mandating of COVID vaccines, these were all reasonable hypotheses to improve healthcare and to improve our response. It was, but the thing that we do in medicine is that we do things and then if we see that it's not really working, we change. And so when it became obvious that COVID vaccines didn't stop transmission, I don't understand why public health wouldn't have just got up there and said, I would have said, look, this was our theory to improve things, but now it's not. And so we're changing the mandate. And we tell patients this all the time. Same with the mask. They could have just said, we really wanted to stop transmission, but it's obvious that it didn't. And now where you can wear a mask if you want. And then trust would have been built up. And we wouldn't have a decline in vaccines that actually work for children, and we wouldn't have these off-target effects. And so I don't know. I could be wrong, but it just seems like a more humble, transparent, honest approach would have been better.
All right. That's really well said. Okay, we're all going to do one closing thought, then we're done. Okay. I'm going to take the moderator purview and go first. Then we're going to go to Tracy, and then we'll go John to close us out. Okay, my closing thought. I left out a part about my randomized trial that I would just come to real quick about exercise, which is the reason I mentioned the baseline exercise and the fact that I'll randomize you to like 20% more and 50% more is that I want my trial to be so big that I can actually pre-specify interaction statistics. So like maybe if you do 5 hours a day, you should go to 20% more. But if you go 10 hours a day already, not 10 hours, 10 hours a week already, then it actually is deleterious. So we could actually look at that. So my study is basically a trial of advice, and it has the power to actually give different results for people based on their different baseline. And the last thing I'd say is, I think all of this is advice. Like people are doing this study about elite athletes because they want to advise like a healthy person, don't do too much or you should do too little, knowing that they're not good. So I think like the commodity is what should you advise people? Okay. And then the last thing on the COVID policy, my closing thought is, I think you both, I really do agree with you profoundly, John, and I agree with Tracy profoundly on these issues. And I think they have not learned anything, and I think it's just going to get worse. It's just going to get worse. And here's the one thing that I know that they haven't learned. We have had 0 debates at my university on any of these issues. 0 debates at the university that I can think of. 0 Zoom town hall debates about people cannot hold the hand of their father when the father dies. 0 debates on masking kids. Even though The Atlantic is talking about people arguing on Twitter, 0 debates at the university on masking kids. 0 debates on our own vaccine mandates. We had a vaccine mandate. We fired some people. Aaron Caretti is one from UC Irvine. He's fired. We had a booster mandate. We fired a few more people, I think. So I hear. We have a third, thing where they finally got tired of firing people because now there's no one working anymore. It's hard to find a doctor in this town because we fired everybody. No debates, no debate, no like we're going to ask some folks in ID. We have roundtables on COVID. They're just all with people who disagree with us and who all have the same view. That's acceptable, the Fauci view, but nobody is allowed to debate. There's no debates on masking policy. Even today, there's no debates on mandatory hospital. We've had no debates. Jay Bhattacharya at Stanford, they have debates in the law school. There's a heckler, but they're not debating the COVID policy. They won't even have that debate. And so to me, what has happened, this is the academy. You had you're doing policies you've never done in human history, and you will not debate at Harvard or Stanford or Yale or UCSF or UC Irvine. You're not going to debate. 0 debates, 0 randomized trials of masking, and 0 debates. And that tells you they have not learned anything. Universities are, I think they can go like Silicon Valley Bank. They can crumble because if a university won't debate difficult ideas, it ceases to have value in society. This podcast has more value than these universities. And Joe Rogan podcast is already having more cultural value because he's going to actually debate, even if he's an imperfect debater and imperfect in many ways. So universities are going to go bankrupt like this. And I really worry that we are so vulnerable. I wrote that thing about democracy. Everyone was mad at me about that these kinds of decisions actually do undermine democracy. But I really think they do. All right. Those are my closing thoughts. John, and then Tracy, or Tracy, then John, Tracy, then John, and then we out.
Yeah. So I think that I want to say that the truth will always come out. And I think we've seen that a little bit already. And one of the ways that we saw that was that now, California is not able to mandate this vaccine. A lot of people are saying it doesn't stop transmission. And I was asked to write an editorial in the LA Times. But people are sort of covering up what we initially knew, which is really problematic. But that I think that people will be able to sort of like I mentioned in my article, we actually never had evidence from the beginning that the vaccines would stop transmission. And so I think that eventually we're going to come around to learn everything is going to come out at some point, and that, the people who are covering it up will end up looking bad. But it gets back to debate, actually, that, it's not just the universities, because Jay and I were just talking about this, actually, how like when we're on the Public Health Integrity Committee, that one of the things that we look forward to doing is debating and with each other. And that's what we're doing on this show. And that's, we haven't seen any of that from the CDC. We haven't seen any of it in the media. It's not just the universities, it's our entire culture. But Europe has been debating all along. So the last thing I want to say is I want to say happy birthday to my mom because she's listening.
Happy birthday, Tracy. That's a nice way to end.
My closing is 11 words. Those who cannot remember the past are condemned to repeat it. Jorge Santayana. So we need to study the history, and we need to learn from it, and we need to be humble about what we got right and what we got wrong.
Thank you all for doing this. Great episode.